Thank you for that inspiring talk, Michael. Please stay seated for the next session, session 15.00, Advances in Translational Science Using Biomarkers to Select Therapy.
And we'll have our speakers all come on up. Yes. Well, Nasli will be starting, but we've got this right here. Great.
Good afternoon, everyone. Welcome to the session 15. We will be talking about emerging biomarkers in renal cell carcinoma. I'm Nazli Dizman, and I'll be chairing the session with Dr. Eric Singer.
Hi, Eric Singer. You're in for a treat. I guarantee this is the best session yet today. Go ahead, close those laptops. Your Epic inbox will still be there, I promise. And we're going to stick the landing and get everyone out to lunch on time. All right.
Okay, great. Well, you heard the boss. First we have Dr. Adam Case, who's going to be talking about novel biomarkers headed from Translational.
All right. Well, thank you to the organizers for the opportunity to speak today, and thanks for those that stuck around. I think it'll be a great session. So let's review biomarkers. So learning objectives. So really going to look at understanding the eras of biomarker development for renal cell carcinoma. And so as we know, over the last decade, the landscape has really changed, over the last 10 years, thanks to the great work by Dr. Friedman, who was our keynote speaker yesterday, with the incorporation of immunotherapy, really just changed everything. However, we still need really good biomarkers to help for therapy decision-making, finding new targets, and for better prognostication. And so when I was making this talk, I was doing it with my daughter next to me, and I asked her, I was like, hey, help me come up with a theme for today's topic. And when you ask a 12-year-old girl, you come up with Taylor Swift, of course. So we're going to go over the eras tour of biomarker development and RCC. And the topics we'll review are the albums, if you will, IMDC, histology, genomics and RNA, imaging, and then we'll finish it off with circulating biomarkers. So the IMDC era, really this was a great model early on in the pre-immunotherapy era, which really helped with prognostication. You can see there overall with the risk stratification, how it's changed over time with favorable risk, intermediate risk, and poor risk, with the introduction of immunotherapy really improving the overall survival over time. And then naturally, because this was the best that we have, it was really incorporated into the immunotherapy clinical trials for risk stratification. And as you recall early on with Checkmate 214 with ipilimumab, nivolumab versus sunitinib, that for the favorable risk group, the responses and progression-free survival was actually favoring Sutent. And so originally in the NCCN guidelines for favorable risk disease, it was not included as a Category 1 recommendation. But with the updated analysis with Checkmate 214, you can see the overall survival of the curve separating with a trend towards benefit. And then the duration of responses in these favorable risk patients was a lot better with ipilimumab, nivolumab compared to sunitinib. You can see around the 2-year mark is where the curves cross together, where they started to divide. So moving on to histology. So immunotherapy really improves outcomes in patients with sarcomatoid and rhabdoid RCC histology. We've seen that with Checkmate 214, with the progression-free survival really separating nicely. And then also in retrospective analyses in non-clear cell RCC, you can see there with overall survival of separating, and we saw Dr. Dashi did a talk yesterday with chromophobe and immunotherapy. So also important that it improves outcomes. So with genomics and RNA era, so genomic features associated with exceptional response to immunotherapy was assessed in Javelin Renal 101 in Checkmate 214 in a recent publication in Nature. And so what they looked at was exceptional responders who got immunotherapy with either IO doublet or IO VEGF. And exceptional response was defined as patients who got complete response that lasted for 12 months or who got a partial response that either lasted 2 to 3 years, depending on how significant of a response they achieve in terms of tumor shrinkage. And so you can see here that clonal neoantigen load was associated with an exceptional response to IO doublet. They also saw that TMB was not associated with exceptional responses. In terms of the IO VEGF, intratumoral humoral responses and tertiary lymph node structure was associated with ER. And you can see there with plasma cells, T cell CD8s, memory B cells, all favoring those with exceptional responders. So this highlights that T cell and B cell directed anti-tumor immunity is important for immunotherapy response. Moving on to RNA-seq to predict response. So a lot of great work has been done here separating patients into clusters with a more angiogenic molecular type or an immunomolecular type, or clusters, if you will, with T effector proliferative clusters 4 and 5. As you see here, favored immunotherapy group with atezo-bev versus those with Sutent. And the OPTIC trial, which I know Dr. Hake is going to be reviewing this, so I know he'll give some excellent updates on this, but this is a trial that's ongoing. And then the imaging era, so as we heard pretty much throughout the whole weekend, CA9 as a diagnostic and therapeutic target is promising. And CA9 is molecularly related to VHL in terms of their relationship. So when VHL is disrupted in clear cell RCC, HIF1 is able to allow for a more hypoxia-inducible genetic factors to get upregulated, which allows for a more pro-angiogenic state and also increases CA9 on the cell surface, which is why it's highly expressed in clear cell RCC, which obviously prompted interest for developing PET agents towards this. We also heard that zirconium-89 garentuximab has great sensitivity, specificity, which was shown in a phase 3 clinical trial. There's another PET agent that we just heard about previously, gallium-68, and this is a peptide radionuclide for staging of clear cell RCC. And some data was just discussed at ESMO, or presented at ESMO just last month, and showed that detected 98% of evaluated lesions compared to 40% detected by standard CT. So just naturally, whenever you have your target, doing therapeutics is the natural next step. So a lot of nice trials that are ongoing, bringing radionuclide therapies to RCC with antibodies, with garentuximab, but also with peptide constructs. So ctDNA, this was a study looking at ctDNA pre-op, so before nephrectomy and then post-nephrectomy. You can see ctDNA was positive in 65% of patients, and then 94% of patients were able to clear their ctDNA, and when it was cleared, 0 relapses occurred. On the right-hand side with the blue chart, you can see in the pre-nephrectomy positive ctDNA group, those were positive in patients with just higher risk histology and staging. And the ctDNA can also predict recurrence. This was ctDNA that was found positive either pre or post the operative setting. You can see if it was positive, you had a lower recurrence-free survival. I'll let Dr. Basu, my colleague, discuss that in more detail. And then KIM1, just going to touch on this briefly, but really getting a lot of traction for good reason, really has been predictive in the early detection setting, prognosis, adjuvant, as well as metastatic outcomes, which we'll hear about shortly. And then lastly, I want to talk about in the circulating area, also related to the gut dysbiosis, leading to loss of MADCAM1, which can increase an immunosuppressive tumor microenvironment. And so it's been shown in animal models that when antibiotics are given, really causes this dysbiosis within the gut and microbiome, which can lead to MADCAM1 decrease. And when you check the microbiome after antibiotics, you can see that there's another species, this enterocloster genus, that can get increased, which also causes downregulation of MADCAM1. And the reason that's important is MADCAM1 is a ligand for alpha-4 beta-7, which allows to keep immunosuppressive T cells in the gut rather than allow them to transiently go outside into circulation. And so there's also been studies that have showed in patients with metastatic cancer who have a high enterocloster genus in their stool have had lower responses to PD-1 inhibition. And so as part of that, this was a study that was presented at ESMO just last month with great work by Laurence and others at Dana-Farber as part of their collaboration. So it was shown that in multiple trials that higher MADCAM1 was associated with a better progression-free survival and overall survival. And what this was really looking at is it allows that MADCAM1 keeps those immunosuppressive T cells in the gut rather than allowing them to go to the tumors, to the lymph node environment that cause an immunosuppressive state and decreasing the efficacy of immunotherapy. And so you can see there the hazard ratios across different trials where patients with higher MADCAM1 had better overall survival. So take-home messages, so practice on Monday. So sarcomatoid histology really represents probably the most clinically actionable biomarker right now for responses to immunotherapy. Multiple biomarkers have been assessed with historical cohorts, providing optimism for predictive and prognostic utility. However, incorporation of more diverse, multifaceted biomarkers into prospective clinical trials is needed to better predict outcomes, guide novel therapeutic discoveries, and minimize toxicity for our patients. Thank you.
Thank you, Dr. Case. Excellent overview. Next up, we have Dr. Basu, GU Medical Oncologist at Mayo Clinic, Florida. He's going to talk about liquid biopsy in RCC.
Thank you. And great talk, Adam. I think that talk deserves to be certified platinum. So my talk today, thank you, first of all, to the organizing committee for the invitation. My talk focuses on the role of liquid biopsy in renal cancer. The objectives are to review the current evidence for liquid biopsies and ultrasensitive ctDNA detection in RCC, and then understand potential future applications for ultrasensitive ctDNA assays. So 1 gram of tumor has 1 billion cancer cells. And all these cells are connected to the circulation because they require nutrients and oxygen. Similarly, cellular products like DNA and RNA are also intimately connected with the circulation. It's a very dynamic marker with a half-life of only 2 hours in the circulation. This provides us with a vast range of potential applications, such as looking at RNA, DNA, proteins, and others. We will focus more on the DNA aspects on this talk. There are many applications even with circulating DNA, which starts with, say, cancer early detection, tests like MCED, tests like Gallery, and others. Molecular profiling or prognostication. These are tests like Foundation 1, Guardant 360, which we use to assess specific markers in the cancer, and until now has been the biggest use case for liquid biopsy. There are also some emerging use cases, which are the detection of residual disease and monitoring of response, along with monitoring of clonal evolution. Sources of ctDNA in micrometastatic disease are not homogeneous, and you can have hibernating cancer cells, single-cell DTCs, and micrometastasis. This is of relevance in cancers which have diverse biology, like renal cell, where you may have a higher fraction of hibernating cancer cells, for example. RCC has presented a challenge when it comes to ctDNA detection historically. In this cohort of 640 patients with advanced malignancies, you can see that urothelial and colorectal shed really well with almost 100% detection, but RCC was among the lowest yield. This is another study out of China with a very large sample size, and you can see that trend is still maintained. So what do we see when we use traditional liquid biopsy in renal cell? What's the historical data? This is an interesting analysis looking at matched tissue and liquid biopsies in renal cell carcinoma patients using a traditional NGS assay, the Tempus assays, done by Dr. McKay and colleagues. And you can see when it comes to concordance analysis, VHL mutations, which are quite frequent in renal cell, about 70% of those were only detected in the solid tumors. They were not detected in circulation. Similarly for PBRM1 as well. And when you look at alterations like TP53 and ATM, a lot of these are just detected in liquid biopsies, suggesting that these are biased by CHIP mutations. All of the sort of depressing data that we reviewed so far, however, comes from first generation NGS tests, which you can see here on the top on the chart here. There are some newer generation tests being developed with much improved sensitivities and limits of detection. These are mostly called residual disease assays, MRD assays, and there are two broad groups. One is an off-the-shelf method where a large cohort of patients with recurrent cancers and mutations are pooled together and a signature is developed, and then it is used for everyone. There is, of course, another approach, which is the individualized approach, where the tumor is sequenced out, specific alterations are found, which are only found in the tumor, and then a probe is created to detect that. We will mostly be focusing on tumor-informed ctDNA information in our next slides. This is one of the earlier analysis of tumor-informed ctDNA in RCC. This was a biorepository sample analysis at Fox Chase. 45 patients over a very long period of time, samples were collected, were banked. Most of these were stage 1 to 2. And I think Dr. Case mentioned preoperative MRD detection was around 50%. The good thing about this study was because it was tumor-informed and a lot of patients were not treated, the positive predictive value for recurrence was 100%. This is another study led at NYU using the whole exome-based assay. And you can see that it's a powerful prognostic factor at the MRD window, which is 13 weeks post-surgery. The median lead time on patients who were on adjuvant therapy was 15 weeks, and the negative predictive value was 92% in the MRD window, and it improved to 95% longitudinally. This is a study that me and my colleagues did in metastatic disease. These are all, again, whole exome-based assays. And we looked at ctDNA kinetics in patients who are both being actively treated, which is cohort A, and patients who have low volume disease or somewhat indolent disease, and we are surveilling them in cohort B. And you can see that the clearance of ctDNA during active systemic therapy correlated with favorable prognosis. And in both patients and patients who were ctDNA negative did really well with observation, while those who were being observed but were positive for ctDNA did in fact progress pretty quickly. This is some data from Dr. Anambakam at the University of Oklahoma, who also looked at a similar cohort, but he had a non-metastatic cohort as well as a metastatic cohort. You can see on the left that in these 34 patients with non-metastatic RCC, the sensitivity of recurrence was 100%, even though there were really just 2 recurrences. And in the metastatic cohort, we again see this powerful prognostic effect of ctDNA positivity with a wide separation of the curves. So now we are going to move on to the third generation of tumor-informed ctDNA tests. We could call it third generation. Until now, we were talking about tumor-informed panels that are based on exome sequencing, but now there are whole genome-based panels being developed. This is a large study being run in Japan. I think the Myriad colleagues mentioned about this yesterday. This is Japan's Monster Screen 3 trial, which embeds a lot of biomarkers. And the Myriad Precise assay was looked in the definitive cohort, so patients getting surgery and then further followed for adjuvant therapy or observation. This cohort actually did include about 7% of renal cell patients. This is early data, but it looked, again, like the same trend, where ctDNA negative patients did really well, and ctDNA positive patients relapsed pretty quickly. On the right, you can see the chart where you can see, because of whole genome sequencing, the number of confident variants is actually increased almost 100-fold, showing the promise of whole genome sequencing approach. This is data from the Signatera assay, and this is the Signatera genome assay as well that was presented at ASCO this year. This is a pan-cancer cohort of 275 patients. Again, you can see a wide separation of curves. This cohort also included patients with renal cell carcinoma. You can see here that with the use of a whole genome approach, the LOD50 has improved from 17 parts per million to 5 to 9 parts per million, with the lowest detected confidently at 1 part per million. This is data from that study, but we presented it separately at ESMO, teasing out only the renal cell patients. And you can see with longitudinal ctDNA monitoring, it separates a population out, which is going to do favorably compared to patients who are going to progress very rapidly. The median follow-up on this study is almost 2 years. We also had 2 other cohorts on this study, which were patients, again, with the TRM cohort, as well as surveillance of therapy in a potentially metastatic setting. And you can see, again, a pretty powerful prognostic effect of ctDNA. Some recent data was, again, published using Myriad's Precise assay. This is Dr. Tang's paper, which looked at radiation as the therapy modality for RCC. And you can see here, pre-therapy as well as post-therapy, ctDNA is providing powerful prognostic information. This is a study which we led at UAB, where we used a high-intensity testing approach with whole exome sequencing, where you can see that in a 120-day MRD window, we performed up to a median of 3 MRD tests. And we assigned therapy based on MRD results. This is a retrospective as well as prospective cohort because the study was impacted by Keynote 564 overall survival results. So a lot of the data is from prior to the OS results being reported. But we did see a powerful, again, separation of curves, and patients who were treated on an MRD-directed strategy had an estimated 1-year DFS rate of almost 86%, while we are sparing a large majority of patients any therapy. So we will see how that evolves as the data evolves in this space. So the case for ultrasensitive ctDNA. Excellent sensitivity, specificity, and lead time are the key to clinical adoption of MRD. Specificity, especially with tumor-informed MRD, now appears adequate. Sensitivity and lead time are correlated and currently lag diseases like urothelial cancer. But novel technologies are now driving improvements in LOD50s. Higher intensity testing can also improve longitudinal sensitivity. Ultrasensitive ctDNA requires prospective validation in clinical trials. And there may be value in combining biomarkers like KIM-1 to augment sensitivity. My take-home message today is that ctDNA positive patients in a surveillance setting, either metastatic or localized, appear to have a significant risk of progression, so monitor accordingly. Thank you.
Thank you, Dr. Basu. Next, we have Dr. Shu. His presentation title is Kim1, Are We Getting Close to Prime Time?
Thank you, Dr. Disman and Dr. Singer. This is a really exciting session, and it's fascinating to see all the progress being made among multiple fronts. Thank you for the invitation to talk about Kim1. You've heard about this now from several prior speakers, and we'll go into a little bit more detail. Learning objectives will review the preclinical and clinical data for Kim1 as a predictive and prognostic biomarker in kidney cancer, and we'll discuss some potential applications in future trials. I want to start with acknowledgements. The Kim1 story, a lot of people have been moving this forward, really for even the past 20 years. And I don't have time to thank everyone individually, but just to point out that many collaborators, mentors, and mentees, most of whom are in this room, have contributed significantly to the Kim1 story. And many of them are listed here. And of course, you already heard today from Dr. Albiges, who led the iEmotion 10 Kim1 analysis as well. And I really want to be really grateful for all the collaborators over the years, as well as our industry collaborators who have given us access to their samples, without which many of these would not be possible. And specifically our funding sources, including in particular the CDMRP, Academy of Kidney Cancer Investigators. Many of you are involved in that program. Has been critical, as well as the R01 grant for Kim1, where the PI is Dr. David McDermott, provided a lot of our funding. So the background preclinically for Kim1 really goes back 20 years. And 20 years ago, Dr. Joe Bonventry in his lab identified that Kim1 is overexpressed in renal cell carcinoma, including clear cell RCC, and is detectable in urine and plasma. And several years later, Dr. Rupal Bhatt, who was my mentor during fellowship, identified that if you look at patients who had a diagnosis of kidney cancer and retrieve their banked plasma from 5 years before in a primary care cohort, you could see that Kim1 was elevated 5 years before the diagnosis of RCC, suggesting this could be a sensitive biomarker for detecting kidney cancer. And the story of Kim1 biologically is quite a complicated one, and Kim1 has multiple roles, both on the tumor itself, but also in the tumor immune microenvironment. And if you might notice, the first paper here, the first author is actually Dr. Gordon Freeman, who you heard from yesterday in the keynote session. And Kim1 has an immune regulatory role. It's expressed on Th2 cells, it's a co-stimulator for T cell activation, and Kim1 blockade ameliorates graft versus host disease, among other things. And human polymorphisms in Kim1, or TIM1, are associated with allergy, asthma, and autoimmune disease. Increasingly, we found, not me, but the community has found, that Kim1 has a role in B cell immunity in the tumor microenvironment. And so Kim1 positive regulatory B cells suppress the immune response. And in this fascinating work, including a Nature paper from 1.5 years ago, it's been seen that conditional deletion or inhibition with an antibody of Kim1 in B cells potentiates PD-1 responses in a melanoma mouse model. And so with that background, in kidney cancer specifically, the very unique role of Kim1 is that Kim1 is shed in very high quantities from RCC. And it can be detected easily using a variety of methods, including sandwich immunoassays. And compared to other assays, Kim1 has some advantages. You only require 25 microliters of plasma per assay, 50 microliters for duplicate. And this slide is slightly outdated. With inflation, it's no longer $10 per sample, it's now closer to $40 per sample, but still very cheap. Over the years, we and others have looked at multiple trials and clinical cohorts and identified Kim1 as a detection, prognostication, and treatment evaluation tool across the clinical spectrum, including the trials shown here. Starting with the pre-nephrectomy setting, Kim1 is able to help distinguish between a benign versus a malignant renal mass. And we looked at this in several cohorts, including a European cohort, as well as one from Johns Hopkins, where using a Kim1 cutoff identified in a training cohort, the validation cohort identified a sensitivity of 92.5% and a 60% specificity for using plasma Kim1 to distinguish a benign versus malignant renal mass. And additionally, the pre-nephrectomy Kim1 level helps to stratify your risk of metastasis and death across these several cohorts here. In the adjuvant setting, if your Kim1 remains high after kidney cancer surgery, those patients are at much higher risk for recurrence. And we saw this across several randomized adjuvant phase 3 trials in retrospective analyses of banked plasma from these trials shown here. So it is a really good prognostic biomarker in the adjuvant setting. And as Dr. Albija has already presented and alluded to, it was really exciting to see that KIM-1 is the most enriched protein out of a panel of over 3,000 proteins assessed using the Olink assay in patients who had recurrence after nephrectomy. Not only that, but patients with high KIM-1, about 50% of this cohort, had DFS benefit from adjuvant atezolizumab, whereas the opposite was true for patients with low KIM-1. And a very similar signal was seen in Checkmate 914, suggesting that KIM-1 high patients may be enriched for benefit from adjuvant immunotherapy. In the metastatic setting, we also see that pre-treatment baseline KIM-1 is associated with worse prognosis. This is Javelin Renal 101, analysis led by Dr. Mark Machalani and others. And also, if you look at the change in KIM-1 from baseline to week 12, patients who dropped their KIM-1 on either treatment arm, sunitinib or axiavelimab, had better outcomes. So decrease in KIM-1 was associated with response. What leads to high KIM-1? We've seen that patients in the metastatic setting with high circulating KIM-1 not only have more tumor burden, but they have more highly proliferative tumors, and they have lower angiogenic scores and lower tumor hypoxia scores, suggesting overall worse tumor biology. Looking again at the adjuvant setting, we saw a really interesting signal, which is that if you have no radiographic disease, but your KIM-1 is rising during surveillance, these patients have a much higher chance of subsequent radiographic progression in IMMotion 10. Really raising the question of, is there a new disease state of biochemical relapse that we can intervene on in kidney cancer? Using KIM-1 as an immune monitoring tool, we looked at 3 trials, asking the question, for patients on immunotherapy, either nivolumab or ipi/nivo, can the 3-week KIM-1 ratio identify who are the durable responders from immunotherapy? And a very consistent signal was seen in 3 trials, Checkmate 009, Checkmate 214, and Cosmic 313. In all 3 trials, patients who decreased their KIM-1 had better long-term responses, and this is using just a 3-week KIM-1 ratio compared to long-term clinical outcomes. Looking at this in a tabular format, you can see when you look at the 3-week KIM-1 ratio in Checkmate 214, each successive decrease in KIM-1 category was associated with better outcomes. This was validated in Cosmic 313, as presented recently at ESMO, again showing a consistent OS benefit at serial time points, whether it's week 4, week 7, week 10, or week 14, where decrease in KIM-1 consistently predicted better long-term survival. And we were also encouraged to see that most patients who had a radiographic response had a KIM-1 response before the radiographic response. And so this really lends itself to asking several clinical questions. And the really theme among all these questions is, can we now use blood tests to make better clinical decisions for our kidney cancer patients? And I'll give a few examples. One question is, we know that adjuvant therapy improves outcomes, especially important now that we have a positive press release for adjuvant belzutifan combined with pembrolizumab. But we also know that most patients are overtreated with adjuvant therapy, and the actual benefit is in a small subset. Can we identify that subset? In patients with low KIM-1 after nephrectomy, who we know are going to do really well and have worse responses to adjuvant IO, should those patients be getting surveillance? And that's a question that we may be able to answer in a randomized way. Second question is the opposite question. We know that patients can relapse despite adjuvant pembro, or some patients who don't meet adjuvant pembro criteria still relapse. About 40% of patients who don't meet Keynote 564 criteria are actually KIM-1 high, and those patients have pretty high risk of relapse. Might those patients benefit from an adjuvant therapy versus surveillance? Question 3, Can we cure biochemical progression in RCC? We recently saw at ESMO really provocative results from IMvigor11, showing that in bladder cancer, if someone develops ctDNA positivity during surveillance, you can intervene on that using immunotherapy. Can we do that in kidney cancer? In patients who have rising KIM1 and radiographic NED, are those patients curable? Can we prevent their metastatic progression? Question 4. This slide, you already saw a version of it presented by Dr. Tian Zhang. This is the Chimera trial being evaluated currently through Alliance. In patients with first-line RCC, we really like ipi/nivo in a lot of those patients because there's a chance for a durable response. But we've also seen that close to 35% of those patients don't make it to 4 cycles of ipi/nivo based on the Pedigree trial. Can we identify early the patients who are not doing well on ipi/nivo? The patients who are doing great with a favorable KIM1 ratio, 1/3 of patients, 85-month plus overall survival, over 70-month progression-free survival, those patients will continue ipi/nivo. But the others, they may benefit from pivoting to an IO-TKI, such as zanzalintinib. And I'll just briefly touch on targeting KIM1. This is really a work in progress. There has been one trial of an antibody-drug conjugate with an MMAE payload, which did not show a good therapeutic window, but other KIM1 immunotherapies are in development based on the really promising preclinical data for KIM1 immunotherapy effect and the blockade of KIM1. So these are my take-home messages. KIM1 is an inexpensive blood-based biomarker with evidence for disease detection, monitoring, and immune response, and is potentially an early response biomarker, especially for immunotherapy regimens. And I encourage all of us to think together about ways that we can do prospective trials that will really prove that using this blood test may help improve outcomes for our patients. Thank you very much.
Thanks, Dr. Xu. Thank you for the great presentation and all your work on KIM1. Next, we have Dr. Haig from Vanderbilt. He's going to talk about next generation RCC gene expression signatures.
All right, well, thank you very much for that introduction, and thank you to the meeting organizers for the opportunity to present here today. So we're going to be discussing RNA-seq-based gene expression assays as a biomarker for selecting therapy for metastatic clear cell renal cell carcinoma. We are all familiar with the central dogma of biology. DNA is the molecule that contains our genetic code. That genetic code is transcribed into RNA, which is eventually translated into protein, the molecule which carries out most biologic functions. While there are many examples of DNA and protein being used to predict drug response in cancer patients, today's talk will focus on RNA, the intermediary molecule. RNA-based gene expression studies have a long track record in cancer. Arguably one of the best examples of gene expression studies in cancer is this classic paper from Chuck Peru and colleagues published 25 years ago and now with more than 21,000 citations. This is a breast cancer study. It's modest size by today's standards with only 45 patients. They used an older technology called cDNA microarrays to measure gene expression of only 8,000 genes, far fewer than modern day transcriptomic NGS-based assays. They looked at breast cancer tumors and performed unsupervised clustering, which, as many of you know, is an analysis tool to group tumors with similar gene expression profiles into clusters. In a simplified form, what this experiment showed there are 3 large groups of breast cancer patients. There are patients which express hormone receptors, and these patients are sensitive to drugs which target the hormone receptor. There are patients which express HER2, or tumors that express HER2, and those tumors are sensitive to HER2-targeted agents. And then there are triple-negative breast cancer tumors which don't respond to any of these agents. And so this is really a great example of gene expression and unsupervised clustering, finding tumors that are grouped together by targetable biology. There have been similar gene expression signatures developed in kidney cancer. One of the earliest ones was the CCA-CCB classification put forth by Rose Brannon, who at that time was in Kim Rathmel's lab. Chuck Peru happened to be located down the hall and I think was an influence on this study as well. He had moved to UNC at that point. Similar size study to the Chuck Peru study, 48 tumors, again using that older cDNA microarray technology, unsupervised clustering was performed, and using these methods, two groups of patients were identified. You have the CCA patients, which are the top line, and the CCB patients, which are the bottom line. And the CCB patients had inferior cancer-specific survival and overall survival relative to the CCA patients. And so, I was fortunate to be involved in some of the early studies with this gene expression signature, and it was really exciting to have a prognostic tool for kidney cancer, but it was not predictive of any specific therapy, unlike the breast cancer experience. Fast forward a few years. So now we have lots of new data sets that have emerged. Here is one. It's been referenced previously today. This is from the Emotion 151 study, which was a phase 3 clinical trial evaluating atezolizumab and bevacizumab versus sunitinib. And so there are a lot of important distinctions between this data set and the CCA-CCB data set that I just went over. One, it's very large, right? The previous data sets were on the order of 50 to 150 tumors. This is over 800. So that's an important distinction. We're using newer technology. We're using NGS-based RNA sequencing rather than the older cDNA microarrays. This is, by definition, a cohort which is embedded with any clinical trial, right? So by definition, we're going to have really reliable, well-annotated drug response data for all these tumors. And the traditional unsupervised clustering was utilized within this study. And so we're, of course, going to be focusing on the RNA-seq. So instead of 2 clusters, which we showed in CCA and CCB, we now have 7 clusters. Shown here are these 7 clusters. 2 of these exhibited a strong angiogenic gene expression signature. These patients in these 2 clusters had a favorable PFS to both the control arm and the experimental arm, possibly because both arms contained a potent anti-angiogenic therapy. These tumors are referenced as cluster 1-2 or cluster angio. We have the tumors which responded preferentially to the immune checkpoint inhibitor-containing arm. These tumors collectively are referred to as cluster 4-5 or cluster IO. Clusters 3 and 6 did not respond particularly well to either arm within the study, and cluster 7 was very small, and so they were excluded moving forward. And so I've been fortunate enough to work with some really wonderful colleagues, and we were able to develop the OPTIC RCC study. The goal of this study was to take these tumor clusters or gene expression signatures that retrospectively correlated with drug response and prospectively evaluate their ability to enrich for drug response. Key eligibility criteria are shown here: ECOG PS01, metastatic clear cell renal cell carcinoma without prior systemic therapies, and tumor tissue available for sequencing, of course. Tumors are being allocated to treatment arms based on their cluster assignments. We presented the results from the first cluster, the angiogenic cluster at ESMO, and I'll review those data today. These angiogenic tumors received cabo-nivo, which of course contained an anti-angiogenic therapy. Our goal was to improve the overall response rate by 20% from the CheckMate 9ER historical control of 55% to 75%, and we utilized a 2-stage design. The immunotherapy cohort, the ipi-nivo cohort, is still actively accruing, and so we don't have data to report. And as we mentioned, clusters 3, 6, and 7 were excluded from the trial, and other secondary endpoints are shown here. We screened 101 patients. So far, this is ongoing. Roughly 20% of patients failed QC during tumor RNA sequencing, typically due to inadequate tumor sample. Several patients were assigned to the immunotherapy ipi-nivo arm. Other patients were assigned to the exclude arm. From these 101 patients, 27 were eligible, signed consent, and went on study. Interestingly, we observed significant discordance between primary and metastatic tumors. So the initial study design was we were going to collect primary and metastatic tumors from all patients. We would sequence both, and we were concerned that the metastatic tumors would, in some instances, fail QC, and so we'd fall back on the primary tumor. But what we looked at when we started analyzing these data is that there was far different cluster diversity in the primary tumors versus the metastatic tumors. The primary tumors were largely angiogenic cluster, whereas the metastatic tumors had much greater cluster diversity. And so we amended the study so that we required metastatic tumor biopsies because these are metastatic patients. It's the metastatic tumors driving morbidity and mortality, and we wanted to target that biology specifically. Here are the results. Objective response rate was 76%, which increased it from 20% relative to that historic CheckMate 9ER. We had some complete responses at 8%, partial responses at 68%. Primary progressive disease was 0%, and 100% of patients had some shrinkage in their tumor. These are early results with a median follow-up of only 11 months. So here's the waterfall plot, which basically shows what I just referenced in a different way. Again, all patients exhibited some reduction in tumor burden. 6 patients had stable disease, but as you can see on this slide, 3 of these 6 patients are really right at the threshold of RECIST criteria for partial response at 27%, 27%, and 29%. 76% of patients met RECIST criteria for objective response. Roughly 60% of our patients that we enrolled in this angiogenic cluster were IMDC intermediate or poor risk, and some of our best responses came from those intermediate and poor risk patients, as you can see on the waterfall plot. So conclusions from this first arm to read out of our OPTIC RCC study. Prospective, and we can do the study. We can biopsy metastatic tumors, we can sequence their RNA, we can analyze the RNA, we can use that data to assign treatment, and we can do this in a timeline that's compatible with patient care and a prospective clinical trial. Primary metastatic tumors are very different, and so we really need to be biopsying metastatic tumors for tissue-based biomarkers, at least this RNA-seq-based biomarker, when we're treating metastatic patients. And selecting patients with an angiogenic gene expression signature enriches for clinical outcomes to Cabo-Nivo. I've shown you higher objective response rates, reduction in tumor burden for all patients, and no patients with progressive disease. The time to event endpoints are very important, and this is an early readout, and we'll be reporting those as we get additional follow-up. The Emotion 151 gene expression signatures are not the only ones that have been developed. There have been several others developed. Here I show the relevant Emotion 151 gene expression signatures, which I've discussed, the cluster 1, 2, 4, and 5. But others have been developed as well. So the Keynote 426 authors developed signatures. Here on the bottom line, you can see that their immunogenic gene expression signature was able to enrich for response to IO-TKI versus TKI within the context of that trial. And Javelin Renal 101 is another study where the authors have been able to generate gene expression signatures. And you can see for their angiogenic signature and for their IO signature enrichment for either single-agent TKI or IO-TKI in the immunogenic cohort. All these signatures are a little different cohorts, different methods, different drugs, different patients, but the approach has been successful in several different contexts. Here we show a Venn diagram for the angiogenic gene expression signatures as well as the IO gene expression signatures from Emotion 151 or our OPTIC RCC study as well as Keynote 426 and Javelin Renal 101. And so not surprising, these signatures were developed with different methods and within different cohorts, and so there's not a lot of overlap, and so this will be an important factor to sort out as these gene expression signatures are developed further. So take-home message, we can select patients with angiogenic gene expression signatures, and we can enrich for outcomes to Cabo-Nivo. And several gene expression signatures exist that have been able to enrich for response in selective populations with really minimal overlap between those signatures. And so it's really important to understand how those different signatures were developed and how best to leverage those signatures for the clinical question that you're seeking to address. Finally, acknowledgements. Of course, want to thank the patients. Without them, this work is not possible. I have wonderful mentors such as Brian Rini and Kim Rathmel, and I appreciate them greatly. And wonderful collaborators, Pedro Barada, Moshe Ornstein, Tian Zhang, Natalia Marr, Katie Beckerman. These are site PIs for the various studies or important contributors, and I'm really thankful for their assistance as well as our data scientists led by Anupama Reddy and our funder at the CDMRP. Thank you.
thank you all for those elegant and fantastic and timely presentations. We have 5 minutes on the clock for some carefully selected questions.
Here. Can I ask a question, Aaron Yang from Ohio State, to Dr. Xu and Dr. Batu? So, in your opinion, the KIM1 and ctDNA, which one is better? Are they complementary? Is there a situation you prefer one over another?
Thanks very much for the question. I don't think they're mutually exclusive. The best answer is going to come in about 3 months when an abstract where Dr. Chad Tang is the lead author is hopefully going to be out, where we are combining those two biomarkers in the same cohorts. But I think that long story short is I think they both provide independent information, and the best results might be from combining them.
Yeah, I completely agree with Vincent. I think each has its own strengths. Like tumor-informed ctDNA has really good specificity. KIM1 cohorts have sensitivity that the ctDNA may not provide. So I think it works best when you combine together, perhaps.
Thanks.
Nizar, and then we'll go to the back.
So great session, really congratulations to the speakers. Scott, question to you. I'd like to believe this approach, this strategy. I really do. But I really think there is a challenge here because we are applying those 7 clusters from the emotions trial, with atezo-bev that obviously is not a standard of care, didn't show improvement of survival. There is the Bionic trial, the French trial, which I'm sure you're familiar with, where it was published recently, where their best results with Nivo-Ipi, 28% CR rate was in clusters 1 and 2, according to those 7 clusters from the Cancer Cell paper. So your second cohort, you decided to treat with Nivo-Ipi the clusters 4 and 5. But how about if those patients with Nivo-Ipi will have the best results like the Bionic trial in clusters 1 and 2? I really think the only way we can answer this is by having this proper control. And I really think we need, with transposing these clusters from one trial to really generalize into how we treat our patients. And I really am afraid we may not be doing the right guidance.
That's a wonderful question, and I appreciate you bringing this up. I think it's important to understand how these gene expression signatures are derived. So I referenced several times unsupervised clustering, and I didn't really explain it adequately because it's it requires a little bit of discussion. So let's have that discussion. So the advantage of an unsupervised clustering analysis is that it doesn't matter whether the patients were treated with atezo-bev or peanut butter and jelly. The clustering is unaffected by the drugs that you give. So we observed angiogenic tumors, right? And we observed tumors that had an increased infiltration of T cells within the tumor. And so in the context of an unsupervised clustering analysis, you should, if it was done appropriately, you should be able to find those clusters in any data set. So the advantage of an unsupervised approach is that it should be more transferable across data sets. Contrast that with a supervised analysis. Okay, so if instead of asking the question, which clusters fall out of this data set, we ask which drugs responded best to atezolizumab and bevacizumab. Well, that's a completely different question, and now you've tied your gene expression signatures to which drugs you used within that clinical trial. And so I agree 100%, those would be non-transferable across different studies. And so I think it's important to think about unsupervised clustering analyses versus supervised clustering analyses and the strengths and limitations of both approaches. The reason the breast cancer experience has been so durable is that, that clustering experiment, which I discussed on my early slides, wasn't predicting response to one aromatase inhibitor versus another aromatase inhibitor. It was simply identifying what are the core groups of tumors present within breast cancer patient. And fortunately, all of the aromatase inhibitors have had some activity in that specific cohort.
Thanks, Scott. Question in the back, briefly.
Yes, I have a question about the ultrasensitive circulating tumor DNA platforms. What do we know so far about non-clear cell tumors and these platforms?
Yes, so I didn't share this, but in the abstracts that we presented, we did have non-clear cell patients, both in the metastatic setting as well as the localized setting. Non-clear cell RCC sheds more, actually. It may be a surrogate of biology or aggressiveness, we do not know, but it is certainly detected pretty, at least on par with clear cell, perhaps better.
Thanks.
Thanks. And final question.
Hi, Elaine Lamb from University of Colorado. Hope you're all enjoying our beautiful Colorado. Dr. Zhu, the data you present with Kim1 is very intriguing, and I wonder if we can move it up much earlier. Is there a role of using Kim1 as a kidney cancer screening tool? And to your knowledge, is this being done?
Yes, thanks, Dr. Lam. So the short answer is yes. I would. We are working on this right now, actually, because of the early data that we showed that if you take a blood sample 5 years before diagnosis, it's already high in Kim1. And so there's an ongoing collaboration with Grant Stewart, who ran the Yorkshire Kidney Cancer Screening Trial from the UK. And they have biobank specimens from there that we are in the process of measuring Kim1 to see if that CT screening trial can actually be synergistic with plasma Kim1.
Exciting. Well, thank you again to our speakers. Fantastic session. Thank you for your participation and great questions.